Dr. Joy Mammen to take over the session. Dr. Joy Mammen is a professor and head of Department of Transfusion Medicine and Immunohematology, CMC VELLORE. He is Associate Medical Superintendent, CMC VELLORE, member of National Hemovigilance Program Advisory Committee, India, also member European Organization for External Quality Assurance Providers in Laboratory Medicine. Over to Dr. Joy.
Thank you, ma'am, for the introduction. I think most of the definitions and why we do quality indicators, why do we monitor quality indicators, and the concept of benchmarking has been very clearly explained by my predecessor speakers, so we won't talk too much about it. I'm just going to go directly into what are the quality indicators that we use and help us to take home some very fundamental and key messages as far as blood transfusion practices are concerned. If you've noticed in the last 1 year, blood banking, if you're on the newspaper, it's most often for the wrong reasons. Nobody talks about the 11 million units which are usually collected and transfused generally in a safe manner to most of the patients who come across our care scenarios. However, the first question that I wish to ask you, and hopefully you're awake by this time, is to check whether you are a repeat voluntary blood donor. All voluntary blood donors can please raise your hands and be recognized. Thank you very much. For all the others, thank you. Give yourself a hand. For all the others, the opportunity is still open, not necessarily here, but when you get back to the place where you work or you study, please make sure that you go back and become a repeat voluntary blood donor. And over the course of this talk, you're going to see why it is important. So the major role of a blood bank or a blood center in our country is, the last box over there, is to maintain adequate blood inventory and make sure that patients who need blood get blood. It's important to remember that blood does not come from manufacturing processes. There is only still one reliable source for safe blood, and that is a safe human being who is willing to donate altruistically. The other important thing to remember is, most often if you look at studies which are published about blood safety and voluntary blood donor programs, you'll find that the most common reason given by people for not donating blood is that nobody asked them to donate blood. For the 1,000 people who are gathered here, I'm asking, and so please go back and donate wherever you came from. Because the important thing to remember is, unless we donate consciously and regularly, there's not going to be blood on the shelf, and blood on the shelf is the blood which is useful in emergencies. The concept of having a WhatsApp message go around and call donors and bring them in, screen them, donate, test the blood is really not an emergency scenario except in mass disasters, and so the blood bank depends on people who donate regularly. So there are specific quality indicators which are recommended by NABH, which is the accrediting organization for blood transfusion services. This is over and above the regulatory requirements which are defined in the Drug and Cosmetic Acts, which governs us. So these are the different quality indicators which are available. And as far as the second one is concerned, I must remind you that it's actually transfusion transmissible infections, because often you see in the newspapers that it talks about transfusion transmitted infections. All the blood which is tested and found positive for any of these markers are usually discarded. They're not given away to patients except in accidental and tragically accidental situations like we came across recently in our own state. So the ones which are highlighted in red are what we are going to talk about in more detail. We monitor the others also, but we pay more attention to these. And NABH mandates that we monitor at least 5 of the published indicators constantly. Because we are in blood bank, we have to maintain regularly mandated registers. We often have much of this data available straight away for us, so it is a step closer to looking at it constantly and monitoring it. And so this is our donor deferral rate, and if you look at it, it's averaging about 25%, which means roughly a quarter of the donors who register at our blood bank at the first instance are going to be rejected for some reason or the other. And I must tell you that the fundamental basis of safe transfusion practice starts with the donor selection. So if your donor selection program does not allow you to reject donors, then you should be very careful about it. And this is especially very traumatic to clinicians who refer their donors to us when we reject their donors, but they have to be advised and they should know that deferral is an important part of ensuring safety. So the lesson here is that we need more voluntary blood donors, and we have several ways in which we are trying to improve engagement with donors. We have different plans for different groups. We are working simultaneously. This is an area which a lot of people pay lip service to, but often do not invest in terms of time and money, not only at an institutional level, but also at the national level. This is a problem. So we're trying to find resources to plug into this so that we can always ensure that there are enough voluntary donors who walk in every day and donate, so that our blood quantum as well as quality remain efficient to the level that we want to. We are on Facebook. Look us up and like us. We really don't expect you from far away to come and donate, but support the cause if you're able to. For those who are local and are donors over here, check out our app on the Google Play Store. It's called Engage. Look for CMC Voluntary Blood Donor app and you'll be able to find us there. The second monitoring feature is the monthly average of transfusion transmissible infections. I'm sorry, I think the numbers are really small over there. But rest assured, the top of the line over there is 5%, and we are kind of well within the acceptable rates of infections which are detected. This can reduce further. This is the overall average of 2.18%. The WHO limits for low middle income countries is 5.1%, and we are well within that limit. Although we know that we can bring this down further, 80% of our 32,000 donations that we had last year were replacement donors. So that means that we are putting a lot of people under pressure to donate, and some of them might not be truthful about what they say. The only way to improve this is to move towards a voluntary blood donor based system. We compare reasonably all right with the country, but we know that there are places that we can improve. Some of our numbers look higher because we use more sensitive tests, and this is the initial reactive results that we put up over here for you to see. As far as discards are concerned, now this is always a concern, especially when it comes in the newspapers. I think last year there was an article in a national newspaper which said that 11 lakhs liters or 5 lakh liters, many lakh liters of blood has been thrown away and not used. One should be cautious about how one looks at data, and this is to let you know that we do have wastages, and we have wastages due to different reasons. However, our wastages are within acceptable limits of what WHO prescribes and national averages. It's about 3% for red cells, and about the rest of the numbers are there for you to see. It is important that wastage for you to understand that wastage will happen. When we look at this kind of a number of 3%, it means we'll throw away on an average about 5 to 6 units of blood every day. But for a blood bank which issues 150 units and collects 30,000 units every year, one should keep it in perspective as to the need for wastage, because unless we have blood on the shelf all the time, we are not going to be able to give blood to the patient. And there is a natural shelf life for many of these. TTI reduction and shelf life can be improved only through improving repeat voluntary blood donors, because that is going to be the safest population for us. We do follow a constrained blood transfusion policy, so we try to reduce the number of transfusions patients need, and we have a very rigorous way of doing it. The average emergency turnaround time in minutes is about 26.5 minutes. It's slightly above our stated internal benchmark of 15 to 20 minutes. But this needs a lot of work, and one of the major abusers of this is our clinician colleagues, because at some audits we have found that more than 50% of our requirements are emergency, and sometimes emergency blood is taken after 24 hours or 48 hours also. So we need to relook at what is a true emergency and educate our colleagues as to how to use it, because once you mark it as an emergency, then the system recognizes it as an emergency. We have done certain things to improve blood flow, workflow, and some of our automation and using of barcodes, and some of the new systems which we are working with will hopefully bring down that. Whole blood to component ratio. Now you know that blood contains plasma, platelets, and red cells, which are the major components that we use. WHO recommends at least 90% should be componented, so that one unit can be used by multiple people based on what the indication is. Our average is more than 95%. There's only a small fraction of our inventory that we maintain as whole blood. So this is something that we are doing all right, but we need to sustain this, and we should also educate our clinicians that they can use appropriate components when they need to. The concept of moving away from whole blood for therapy except for trauma is something that they need to be reminded of constantly. There's also a national program to give away a surplus plasma for fractionation. Adverse transfusion reaction rates are very low. This is primarily because we do not have too much of reports coming back to us, and we need to improve our systems for that. We recognize that is terrible underreporting, but we need to make it different ways to look at, we need to address different ways to look at how we can improve our reporting systems and make it easier for clinicians to report back to us so that we can work on improving our system. There are already certain risk reduction measures that we put into place, but we hope to improve that over the years to come. So the final lessons are that this is constant monitoring, which leads to continuous improvement. We need a lot of communication, and it takes a lot of it takes a lot of teamwork to get this done. So thank you very much, everybody, and we hope you have a nice time here.